Today's discussion is to demystify what happens around the brachytherapy. So sometimes we spend a lot of time understanding that maybe it's the needle placement that's the hardest. It's putting that needle perfectly in the base or at the right part of the apex, or learning how to do hybrid brachytherapy implants. But in fact, the harder part might be, how do we get that patient to that treatment? What kind of preoperative preparations do you need to do? What kind of coordination do you need to do with your gynecologic oncologist to admit the patient? And what kind of considerations do you need for, say, antibiotic prophylaxis or heparin prophylaxis? We thought initially that doing checklists or some kind of consensus might be ideal, but really the heterogeneity of the environments in which brachytherapists practice is just really, really great. And there are institutional variations that are very important that we adhere to. In addition, this is also quite tied into patient quality and safety that I'll let Tim speak about briefly before Tim introduces his practice and some of his tips on his peri-procedural work. That doing high quality brachytherapy is owning all aspects of your care, or being deeply involved in all aspects of your care, pre, during, and post. So to start, I'd like to introduce Dr. Tim Showalter. Tim is a radiation oncologist at UVA, and he's also the chair of the ABS Quality and Safety Committee. He'll talk about how this presentation today is tied into that, and then introduce his practice. Tim, go ahead, go for it. Thank you for joining us.
Great, thank you very much. So I think I was really excited when Neil put this panel together. I think this touches on a really important issue, and it's that we really do spend a lot of time talking about the gadgets and the technology and the treatment planning. But when you're putting together a quality and safe program, a lot of these considerations are what really pushes you to offer good care. One point that I really wanted to emphasize is that local context matters a lot. So what works at institution A may not be the best solution at institution B. And I think the general theme that I always try to emphasize to our residents, but as they're preparing to enter practice, is that ultimately the right sized brachytherapy program may look really different at their center. We have checklists for a lot of the radiation safety parts to make sure that catheter links are measured, but a lot of the clinical elements are things that we don't spend as much time going through. So I'd like to share a little bit about the context at University of Virginia and sort of what our program looks like, and that'll, I think, set a perspective for why we do what we do as we continue in the panel discussion. So first, we should know about UVA is that we're a really small department. We have essentially 6 faculty members. When I started in 2012, I was really the main person for all of these brachytherapy procedures that you see listed here. And we really have kind of a wide variety of procedures that we do. Now there are 4 of us really who devote some time into different categories of this. One big emphasis for us is rapid workflow. Our original sort of lofty driving initiative for this focuses on serving a really broad region. And so we reach into West Virginia, Southwest Virginia, pretty broad area. And so the idea for the structure of our program was originally to leverage this small team who can serve a group of patients who need to get into Charlottesville and then get home quickly. Practically speaking, it also really works for a small faculty. So, having a in-room experience where we emphasize rapid workflow also lets us accomplish a lot with a pretty small team. And it's ultimately something that really resonates with our patients. They're happy that their procedure can get done quickly. I'll show you a slide in a minute of what our facility looks like. But essentially, we have a self-contained badge access brachytherapy suite that's got 3 recovery beds and treatment console, 2 shielded rooms, and one of them is our main room, has a CT on rails within it, and everything is within that area. We perform all of our procedures in that area. We have HDR brachytherapy for breast cancer, all the GYN procedures, and we serve a pretty broad area for tandem and ovoid and interstitial GYN, a pretty high volume vaginal cuff brachytherapy practice. And then our prostate procedures also occur in the same place. So that includes high dose rate brachytherapy boost and salvage brachy. And then we have a seed implant program that also happens in that same suite, and some prostate rectal spacer procedures that a few of us perform. So this is what our facility looks like. We've got gas for anesthesia on both sides of the room, so the cart can be moved around. We've got OR style lighting, and we've got the other side of the room that's not shown is littered with every form of complementary imaging that you can wheel around. So we've got a specimen mammogram unit to support our breast intraoperative radiation therapy clinical trial. And we've got our, of course, our ultrasound unit for prostate brachytherapy and some other pieces of equipment. This is the idea behind it. It's not right for everyone, but we view ourselves as getting everything done in a scan, plan, treat workflow. And whenever we approach a new bit of technology, for example, using MRI incorporated into our GYN program, we remember to emphasize this because we view our role at University of Virginia as focusing on getting things done without moving the patient and trying to understand more about what you can do with that workflow. So we try to avoid moving patients around from table to table. Just to give local context, because I think a lot of our discussion is going to focus on like how to clinically take care of a patient. It's really important to be aware of what we have at UVA and what we're constrained by. So we are severely constrained by anesthesia coverage. We have 2 days per week, and that's it. So we have Wednesdays and Fridays. We are not allowed to do conscious sedation in our facility due to hospital regulations and the relationship between our facility and the inpatient care. So that factors in a lot of how we structure our overall service and indeed sort of our clinical coverage schedule for the week. So we're really careful about how we use our anesthesia time. One related aspect of that is that the way we approach tandem and ovoid brachytherapy, which is one of our more common procedures, sometimes about 150 or so cases per year with a pretty lean team on top of other things. So we do our first fraction only under general anesthesia, and then we use oral sedation for the rest of the cases. So we've adopted a Smith sleeve based approach, which we put in ourselves as the radiation oncologist to support that. We try to seek alignment across our procedures for really in all regards. We have like 5 gynocs and 3 urologists we work with. So we have a intraoperative antibiotic approach. We just use Ansef unless someone has an allergy, because that was a common antibiotic that the gynocs and urologists were both able to give the thumbs up on. We have synchronized and used the same patient instruction sheet for our bowel prep for GYN, interstitial, and prostate cases. So we have them on a full liquid diet the night before, and we use enemas the night before and the morning after. So we actually moved away from magnesium citrate years ago because there was some misalignment among the various stakeholders for that. And we try to focus on rapid workflow as much as possible and minimize the amount of time spent under like anesthesiologist controlled sedation. So I'll stop there and let the other folks introduce their overall programs.
Great, thanks so much, Tim. And again, Tim introduced the idea that local context really matters, as well as creating consensus amongst the referring physicians, including gynocs, neurologists. I think a really neat thing that Tim did was he brought them together to create consensus amongst everyone as a group. So I'd like to next introduce Dr. Stephanie Markovina. Stephanie is an assistant professor of radiation oncology at WashU in St. Louis. And we invite her to show what her program is like and some of the Peri tips that she may have for our group. Thank you. Stephanie?
Thanks, Neil, and thanks to everyone. I'm really excited to be here and have this opportunity to kind of tell you how we do things at WashU. I think things are a little bit different at WashU for a couple of reasons, and I know this is focused on peri-procedural points, but I'll give you just a little bit of a hint about how we treat patients that might be different from other institutions, and that plays into how patients are moving through our workflow. So first, just a basic ground floor plan for our brachytherapy space. So we have a dedicated brachytherapy suite that's shown over here on the right of this diagram that includes two shielded rooms with HDR units. We have what we call waiting bays, which are used for pre-procedural and post-procedural space for patients. And those are the primary spaces that patients will enter. And then we also have two dedicated procedure rooms that we place implants in, both all types of implants. I'll focus mainly on our GYN practice, although we do have a pretty expansive brachytherapy practice for other sites. We have two CT simulators just down the hall that are used for implant verification. And then about 300 feet down this hall, not pictured in this image, is our Taunk dedicated 3T MRI simulator. And we use that heavily particularly for our intact cervix patients. So to just kind of walk you through how the patients are taken through their implant day, they'll come into the brachytherapy suite. They're placed in a waiting bay where they're interviewed. Vitals are taken, blood draws are taken, IVs are started as needed by our dedicated brachytherapy nurses. And they're given some pre-medication, usually if that's indicated for the procedure that they're receiving. Then they're taken to the procedure room where the implant is placed by the physician. The patient then either goes directly to CT simulator or MRR for image verification, or back to the waiting bay if it's not quite their turn in the queue for imaging. And then once they're done with simulation, they'll wait either in these waiting bays or in one of the treatment rooms if they're getting ready to connect the catheters. So that's just an idea of physically where these things happen. And then, for GYN in particular, from a workflow perspective, we really have three types of implants, I would say. One is the intracavitary for post-op endometrium or cervix. These are a cylinder or ring or sometimes ovoids only patients. Those patients, we treat about 5 to 6 overall per week with, a decent range of patients per week. The next section is the intracavitary for intact endometrium and cervix. These, we occasionally will place freehand needles for a combined intracavitary ISI implant, but that's pretty rare with our practice. On average, we treat an average of about 9 to 10 patients per week with the range you can see here. And then the third group is the interstitial implants that we use for, definitive vulvar or vaginal cancers or vaginal cuff recurrences. Those we do about 20 per year with some decent variation, as you might imagine. So just a quick note, as I mentioned, about how we approach the treatment of intact cervix cancer, because this does play a bit into our workflow. We use a combination of a split pelvic PET-guided IMRT treatment to primarily the pelvic and/or periaortic lymph nodes, as well as an early integration of high dose rate image-guided implants. So this is a schema of our treatment approach, whereby patients are receiving 4 days IMRT 4 days a week, and they receive one intracavitary or usually intracavitary implant beginning as early as possible. And so in many cases, these patients are having their brachytherapy start week 1 of treatment. And the right side of the slide is really just to depict what we're trying to do with this treatment approach. And hopefully it's not too small. You can see this diagram here. The IMRT really is intended to treat the lymph nodes. And it's called split pelvis because we intend to have the IMRT dose dip down in the center of the pelvis where the not only bladder and rectum are, but where that tumor is, which seems counterintuitive. We're actually not giving a high dose to the primary tumor with external radiation, but that's compensated by a higher contribution of high dose rate brachytherapy, and that dose distribution is represented here, as I mentioned, starting as early into the treatment approach as possible. And there's just a little comparison, that slide that my partner Perry Grigsby put together to compare to a more standard approach, I think, of delivering a whole pelvic IMRT or whole pelvic 3D conformal radiation treatment plan, where the whole primary tumor plus a margin and lymph nodes are taken to 45 or 50 gray with a lower overall dose HDR brachytherapy implant, leading to a slightly lower dose to the center of the pelvis. Now, this has never been compared, obviously. We think we have pretty comparable disease outcomes. But this is just to give a sense of how things differ a little bit for our for treatment of our patients. And really, maybe what that mostly translates into is a different kinetics in how the tumor shrinks. So if you think about giving really high ablative doses very early to the primary tumor, we actually see a really almost predictable, hopefully in most patients, shrinkage of the tumor that we can see on our weekly MRI implants, and the treatment plan is adjusted as necessary to accommodate for that. So for patients with intact cervix, as an example of how they might move through the day, they're brought in, as I said, interviewed, vitals are taken. They do have a urinary catheter implant placed. Sorry, this bowel prep is not accurate. That was supposed to end up on the ISI implant. We don't give them any specific bowel prep instructions. We do not have anesthesia in our department, so our nurses are delivering the mild sedation in this case. We give Dilaudid for some pain control, lorazepam and hydroxyzine to help with anxiety as anxiolytics and antiemetics in this case. And the patients also will get IV Zofran. And then throughout the procedure, if they need additional analgesics, they're given PRN at the physician's discretion. Most patients receive MR-guided implants. So as I mentioned, they'll have their implant placed and then go for MRI imaging in our department. The average for this procedure from the time they receive their implant to the removal after treatment is about 3 hours for MRI and about 2 hours for CT guidance. And of that, the physician time required is really highly dependent on the difficulty of the implant. So anywhere from 5 minutes for a very straightforward tandem and ovoid to 45 minutes if it's one of those really early fractions and a large tumor with maybe an obliterated Oz, that'll take us a bit longer. But the average probably is somewhere about 15 minutes for physician in-room time. And after that 3 hours is over, after the implant is removed, patients are instructed to come with a driver. So they're not required to recover fully from the effects of the mild sedation while they're in the department. As long as they have a driver, they can leave, and their vitals, we do post-implant vitals, and as long as there aren't any clinical concerns, they're allowed to leave right after that. And then as an example for our interstitials, this I think maybe is a unique approach because most of our patients are treated as outpatients. We also do this down in our brachytherapy suite and procedure rooms. Those patients are prepped with a bowel prep. So they have 2 days prior to implant, they're instructed for a full liquid diet, followed by a clear liquid diet the day before. They do a Fleet's enema the morning of the procedure, and then try to remind them to take some Imodium that morning as well. They have a urinary catheter placed, and it's in place for the duration of the treatment, which in our case, sorry, I should have put this on here. We place the implant on a Tuesday morning. We do 8 BID fractions, including on that Tuesday. And then the implant is removed after the second fraction on Friday afternoon. They do receive the same initial sedation, as I mentioned, for the tandem and ovoid patients or intracavitary patients. And then we also, as a difference from most of the TNOs, we use sterile technique here with draping and iodine prep, and also some local anesthesia. So mostly for most patients for the external sutures, but then if they have needles going through the perineum, we'll also do usually a pudendal block. The procedure duration, considering the physician time, is really roughly about 30 minutes to an hour, again, depending on the complexity of the implant itself. Patients during the course of the implant or the day that they're with us, and then through the duration of the implant being in place, most often will receive oral analgesics. So I hope you don't think I'm lying when I say that most of our patients are managed, their discomfort is managed with Tylenol. Occasionally patients will need some PRN oxycodone, and pretty rarely do we need to increase the analgesia beyond that. The most common reason for patients to be admitted for the course of their ISI implant is that they live too far away from the hospital and or aren't able to manage at home with some help. And then they're given antiemetics as needed as well. And as I mentioned, most of these patients are treated outpatient. We have published this experience that kind of gives the the specifics of how patients are managed. They're all given a donut-shaped pillow to assist in, you know, getting home or in the car if they need to be transported. They're instructed to get up and move as much as they can throughout the course of the implant. So we don't do any anticoagulant prophylaxis other than asking them to continue moving. And they take Imodium every 4 hours throughout the course of the implant. So they are not to have a bowel movement over those four days. So with that, I'll stop and hand it on to the next panelist.
Great. Thanks so much, Stephanie. So I think everyone can see that there are some differences depending on what's available locally between different institutions. And I'd also like to highlight that there is no accident that the pre-procedure preparation at UVA is different than the pre-procedure preparation at WashU, depending on the local context as well as the abilities and capabilities of each institution. What Dr. Markovina also introduced was some of the other issues that seem to come up in terms of DVT prophylaxis, antidiarrheals to prevent bowel movements. So we'll get into that a little bit more in the Q&A, but I would encourage everyone who's on the call, please start typing questions in the question answer box, and then we're gonna go through a lot of questions from pre-procedural preparation and peri-procedural management and then recovery. So next I'd like to introduce Dr. Matt Scala. Matt practices at Kaiser Permanente in Northern California. It's a practice that is chock full of fellowship-trained brachytherapists like himself, and they have a really wealth of experience. So Matt, I invite you to share your slides and some of your experience and tips.
Great, thanks, Neil. I really appreciate you and the ABS inviting me to take part in this today. Okay, so, I just wanted to introduce myself briefly. I'm Dr. Matthew Scala, and like Neil said, I practice out here at Kaiser Permanente in Northern California. And what I would like to do is just briefly introduce our program and then shift gears. I think we're going to get a lot into the particulars during the Q&A discussion, and I just wanted to give some kind of general tips that I've picked on for a successful brachytherapy practice. So this is Kaiser Permanente in Santa Clara. There's a picture there on the left that you can see our main hospital campus. And then on the right is our cancer treatment center. So that's where all our radiation treatments are given. And I think this is such a great format because we can already see just from the two presentations that preceded me, there's a lot of different ways to deliver really high quality brachytherapy. And as you can see from the picture on the right, we're also, it may be a little difficult to see, but we're also a freestanding outpatient center. So this has provided both challenges, but also some opportunities to really design a 100% outpatient brachytherapy service where we're really running the gamut of all types of brachytherapy procedures, but also doing it in an outpatient manner. For those that don't know, Kaiser Permanente is a really large multi-specialty organization in Northern California. We have about 4.5 million members, so it's a very large catchment area. And that really does lend to a lot of case diversity that we see. This is our brachytherapy suite. That's Araceli on the left. She's one of our fantastic brachytherapy medical assistants. We do have full anesthesia capabilities right in our brachytherapy suite, and we're lucky that it's all right in our outpatient department right here. We use a mobile CT for our intraoperative planned gynecologic procedures. And then we also use intraoperative ultrasound-based planning. So all of our planning, I think much like Tim's, is all intraoperative. We've designed our program in a way that we also really try to minimize transferring patients, moving patients. We feel like if the implant can be done, the planning can be done, the treatment can be delivered all in the same position, that really does lend itself to very high quality outcomes and safe outcomes. So in terms of our volume, we do about 500 we have two centers and we do about 500 complex interstitial brachytherapy procedures every year. We do about 300 at Kaiser in Santa Clara and then 200 complex interstitial procedures at Kaiser in Dublin. And we also do a really large volume of obviously intracavitary brachytherapy procedures, perioperative sarcoma HDR brachytherapy, head and neck brachytherapy, and a lot of other things too, lung and some GI and things. So This is just to give you a quick example of our intraoperative mobile CT planning. This is a case that I did earlier in the week. This is a woman with a vaginal cancer, did an interstitial boost there. And you could see the image qualities not quite up to a diagnostic CT quality, but getting fairly close. And so we feel that the benefits of using this intraoperative CT and not having to move the patient to our diagnostic CT scanner is really beneficial for our outcomes. This is our suite in Dublin. That's our sister site. Like I said, they also have a really robust practice there, doing about 200 complex interstitial brachytherapy procedures. And you can see here that they're one of the newest Kaisers. They were actually just opened in the last year or two. So a really nice center there. And I wanted to switch gears and maybe do something a little different here. And I think we're going to get into a lot of the particulars as we get into the discussion. But I just wanted to share some tips that I've learned over the years of doing this for a successful brachytherapy practice, really mainly general things. The first one would be when you're doing a brachytherapy procedure, clear your schedule as much as possible. We're in a really unique position as radiation oncologists where we're communicating with nurses, we're communicating with dosimetrists, with physicists, with anesthesia colleagues. And, as much as we can clear our schedule and be present in the operating room without distraction, I really think that helps. I think of it very much like a general surgeon wouldn't be in the operating room doing a surgery and then also be covering clinic. And I know that sometimes this is easier said than done, but as much as you can clear your schedule out, I think that's really important. We also do get a lot of students and residents that come through. And what I always try to teach them is, they come in and we're very focused on very important things like needle technique and catheter placement, all these different things, ultrasound imaging. And those are also, obviously very important. But to me, one thing that gets overlooked, and it really ties into this pre-procedural preparation, is patient positioning. You can't say enough about patient positioning. If the patient is not optimally positioned, the implant geometry will not be perfect. And if the implant geometry is not perfect, you'll never get as good dosimetry as you would otherwise. Even with complex, inverse planning optimization, all of these things, to me, the positioning of the patient sets it all up. If you have the patient positioned well, the implant is that much more simple and will be that much more high quality. So really important thing to think about. The next thing is I try to review the chart at least twice prior to each case. It seems like common sense. It is common sense, but if something goes sideways in the middle of the case, you don't want to be thinking, what are they allergic to? What was their medical history? You want to have that information right at the top of your mind. And so, we do this at the consult, but the consult sometimes can be weeks or even longer before the procedures. It's always good to just glance at it a couple times right before you do the procedure. Redundancy, redundancy, redundancy. I put this picture of an airplane to just jog my memory. That an airplane has two engines for a reason, right? If one fails, you can still get home safely. And I think this is the exact same approach we should be taking in our brachytherapy procedures. You want 2 ultrasounds, you want multiple of all your equipment, just in case something fails. You don't want to be in the middle of a procedure and not have access to what you need. And something else I would add is, you want to check everything. I mean, again, it sounds like common sense, but if you're doing a tandem and split ring or a tandem and ring or a tandem and ovoid, build that applicator, sterilely, of course, but build that applicator before you put in the patient. You don't want to be halfway through an implant and then realize that your equipment doesn't work, right? You want to build that first and make sure everything is functional before you actually start doing the procedure. Think about bleeding before, during, and after all cases, right? You want to have a plan to address bleeding. You want to have a backup plan, and you want to have a backup plan to that backup plan. You want to be thinking, what am I going to be using by using vaginal packing? Am I going to be using Monsil solution? What if I need to coordinate an emergent referral for a uterine artery embolization? How am I going to do that? You need to think about these things, and a lot of them, 99% of the time, you'll never have to go down those roads, but you just want to be thinking about them as you're preparing to keep everything as safe as possible. And what goes hand in hand with that is you want to have a plan for recovery. When the patient is recovering, what if they have a fever? What if they're in pain? What if they're hypoxic, bleeding, decreased responsiveness? You want to coordinate, with our anesthesia colleagues a lot in these regards. And we want to think through, if one of these things happen, what's the pathway we're going to take? And again, The vast majority of the time, these things are not going to happen, but you don't want to have to be thinking about it in the heat of things. You want to have a plan going in. Brachytherapy is never an emergency. One of my radiation oncology mentors used to say, radiation oncologists, we're golfers, we're not hockey players, right? Meaning we can set up our shot, we can check the wind, we can take our time, we can make that perfect shot. You know, we don't have to rush into things. You know, taking an extra day or two to make sure a patient gets accurately and appropriately cleared from a cardiology perspective, if there's some new, you know, chest pain or something that occurs in the week that you've planned your brachytherapy procedure, you know, getting it done safely, making sure all those clearance, make sure all the testing is done. You know, there's not going to be a clinical consequence to doing that implant the next day or the day after to really safely clear that patient. So it's, in my mind, never an emergency. It's not like a patient with acute coronary syndrome that we need to rush to the cath lab. Another thing that somebody told me is if you want to look really smart, you have to put a Latin phrase in your slides. So here's my Latin phrase. It's primus inter pares, and what it means is first among equals. And that's the way I view our brachytherapy team, and particularly my part in it. We're all equals. Everyone that's taking part in these procedures is equal and valuable. Our team has the experience of hundreds, thousands of these procedures. And brachytherapy is a human endeavor, and we all can make mistakes. And I want our team and you know, all of our teams to feel empowered that if I'm about to do something out of order, or one of my colleagues is, to be able to speak up, to be able to say, wait a minute, you know, the first 1,000 times I've seen you do this, you know, you do it this way, and you know, to question that, because I think that really breeds safety and quality. And so I, you know, really view that first among equals as a much better way to think about it than kind of the captain of the ship approach. Long-term follow-up, you know, our patients are our best teachers. You know, we learn from our own outcomes, you know, learning what was successful, what wasn't. So that's really important. And last but not least, communication is the foundation of everything. Being able to communicate well with staff, patients, colleagues, anesthesiologists really sets you up for success. So with that, I just want to, you know, thank my colleagues for you know, helping build such a high quality, successful program. And thanks again to the ABS and Neil.
Great, thanks so much, Matt. So Matt brings up a number of really wonderful tips that are great for attendings as well as residents as they start their practices. About really a lot of this is around planning. You know, being ready and understanding what your contingencies are going to be in regards to preparation, just double checking the charts, preparing with your anesthesiologist, anticipating all possible adverse outcomes. And it's really, really, really healthy advice to understand what all your options can be. Matt also runs, again, an incredibly high volume practice. And so these experiences are really just, again, helpful for the larger community. Thank you again, Matt. For the attendees, again, please feel free to ask questions through the Q&A. There's several that have been answered already that the panelists are writing some nice answers to, but we can see that there's some variation. Some questions that are coming in include things about oral sedation and Decadron for prostate cases, as well as Dvt prophylaxis. So again, please feel free to add in questions as they come. Next, I'd like to invite Dr. Martin King. Martin is a assistant professor of radiation oncology at Brigham and Women's Hospital, Dana-Farber Cancer Institute. Invite Martin to show some of his considerations for their practice. And following Martin's presentation, we'll go through several different aspects of care. I think first we'll probably talk about pre-op considerations such as pre-admission testing, perioperative antibiotics, heparin, and then maybe we'll go to intraprocedural stuff, and then we'll round it out with the best thing that each panelist did for perioperative care. So Martin, take it away.
Okay, thanks everybody. This is going to be a little short, but this is just a summary in terms of what our workflow is at Brigham and Women's Hospital. So we do have a pretty high volume practice. We do the 3 largest practices are gynecologic, intercavitary interstitial treatments, prostate LDR and HDR brachytherapy treatments, as well as skin brachytherapy. So we do have a shielded OR, and so we have anesthesia. We also have CT guidance. We also have ultrasound guidance, and we also have 2 intraoperative MRI suites, which can allow us to get real-time imaging and to adjust the applicators based on the results of the MRI. So just in this picture down here, you can see that this is our CT scanner. The rest is anesthesia machines. On the other side, we have the ultrasound. So the typical things that you would find in a normal brachytherapy suite. We do run the gamut of both outpatient and inpatient treatments. And so for our prostate LDR or HDR boosts or gynecologic TNRs, we admit patients as an outpatient. So they come in through day surgery. They get their pre-op in the radiation oncology area. We bring them into the brachytherapy OR. We put the applicator in. We get the simulation, ultrasound for prostates, CT for GYN, and then we treat the patient. Then what we do is we discharge the patient, they go to the PACU, and then they go home that same day. We also have inpatient admissions, which these are mostly for our gynecologic TNRs or hybrids or interstitial implants, where we get the pre-op in the radiation oncology area. They come into the brachy OR for implant. We can transfer them under MRI, under anesthesia for MRI guidance. And then we bring them back to the brachytherapy OR for extubation, discharge to the PACU. Then they come down to our unit for the first treatment, and then they're admitted to the inpatient gynecologic service. So I just had a few points in terms of our workflow issues that we have. All of our patients require pre-anesthesia testing if they're going to get anesthesia support. This can be complicated for many of our patients, especially the ones that are more elderly. But as Matt said, I think it's absolutely critical. No one wants to have one of a medical event within the OR. And so we really take this very seriously and work closely with our anesthesiologists to try to get patients the curative treatment that they need in the safest way. For perioperative medications, we give ANSTA pretty much to everybody unless they have an allergy. For prostates, we use 4 milligrams of Decadron to try to decrease the swelling. We do use Epic order sets. That does help us really, decrease, just kind of having everything together. And we also have order preferences, so we make sure that we don't forget orders. And the last point, I think, is really communication. So communication is so key in what we do. I think that for services where we admit to, like the GYN service, like they're almost our best friends. And so we always make, sure that they can see our orders, that we tell them of any medical issues, any consults that the patients need in the PACU. And we try to get the patients as tidied up as possible, call all the consults, so that when they get to the GYN floor, they know exactly what to do. They don't have to put in orders anymore. And we know they're very busy too, just taking care of a lot of patients. So we try to do everything that we can on the radiation oncology side so that when they get up, the patients are comfortable and stable. We do use epidurals for our interstitial implants. We also use PCAs. So we do give a lot of pain medications for our patients. But I think every extra thing that you do also does take some more time. And so that's really all that I have.
Great. Thanks so much, Martin, for sharing those experiences and some of the workflow tips that you've started. So all of our panelists have introduced their practices. We're going to just start asking some questions. We'll start with some pre-procedure considerations. And one of the things that I've learned from Pete is that these are kind of the back of the hall conversations that you have with your colleagues at the ABS meetings, which you should all register for, about how do you do this and how did you get this done and how do I get that done? So again, please invite your questions. So let's start with some preoperative considerations. And I think, Martin, let's start with you and everyone else. If you have some thoughts, please chime in. You'd mentioned pre-admission testing. and blood work for some of these patients getting anesthesia. So I'll start with our experience and what we do at Penn Medicine, and Martin, maybe you share with what you would normally do. So for us, most of our GYN implants all get general anesthesia. We have access to an ambulatory surgery center that's not in the department, but it's next to the department, which is very helpful. But again, following the local safety and regulatory practices, we do get pre-admission testing, CBC, comp, coags, as well as a type-in screen, just in case. We've only had to transfuse a couple patients. So Martin, what kind of blood work do you get? And after that, what does everyone else do? If they get blood work at all?
So before COVID happened, we got blood work on most of our patients. So they would be CBC, CMP, PT-INR was controversial. For sometimes they didn't think it was necessary, other times they did. LFT, and so those are pretty much, and type-in screens, sometimes we got it, sometimes we didn't. Sometimes it was just for patients getting like an interstitial implant. That was pre-COVID. Post-COVID, the only test that everyone gets is the COVID PCR test before the implant. And so a lot fewer patients are getting blood work or PSA levels. But the patients that we really monitor their blood work are the GYN patients who are getting chemoradiation before. And a lot of these patients are coming from outside of our system. And so we actually have a PA who really follows up and makes sure that we get labs and coordinates them with outside centers so that we can make a decision on whether their labs are okay to undergo implant or not. But yeah, the amount of pre-op lab testing has markedly decreased since COVID.
Great, thank you, Martin. Any other panelists, the specific blood work that they really like getting or they really don't like getting?
Well, not for blood work, but I would say one thing that comes up a lot is cardiology evaluation. So we send all of our GYN patients to like the general hospital pre-admission testing center, and they get a quick anesthesia H&P there, and they get lab testing and an EKG. And often in that situation, especially for our elderly patients, we find that someone was really supposed to have an echocardiogram or something done, especially now during pandemic-related delays. And so we'll have to make sure that that happens ahead of time. We send our GU patients to the urologist, to the urology department's nurse practitioner, and they serve that role for us. But we found it really helpful not only to have the labs, but to have those discussions ahead of time to make sure to avoid delays.
Great. Thank you, everybody. So sounds like some local practices are, depending on what admission needs and anesthesia needs you need, are really important. And I think Tim brought in a good point that using your institution's resources and other departments perhaps to help you leverage delivering the best care for patients and those evaluations. Let's move on to what seems to be coming up a couple times with some questions about perioperative antibiotic use. Tim had mentioned that they agree to cephalosporins with between GYN and urology. Matt, what do you think about perioperative antibiotics? Which do you like to use? Which do you hate to use? What do you want to use? What do you have to use?
Yeah, I think that's a great question, and on its surface, a simple question, but then you dig deeper and it gets a little more complicated, right? Our main antibiotic that we use is cefazolin and cef, really just with the thought that these are percutaneous procedures. We want to cover skin flora. We want to cover gram-positives. If we have a concern, if there's an anal rectal implant we need to do or something where we also want gram-negative coverage, we would think about antibiotics like metronidazole, ciprofloxacin, these types of things. I think the other comment I would have is, we see quite frequently patients coming in with penicillin allergies. And how do we manage that, And I've had a lot of conversations over the years with different folks, and different people have different opinions on that. A lot of the anesthesia colleagues I work with feel very comfortable, giving a dose of Ancef in somebody who has a penicillin allergy. And I think a lot of it has to do with Number one, the common sense stuff. We always go back to that. What is the allergy? What happens? Is it really an allergy? If it does seem like it's really an allergy, it does seem like there's data that indicates that some of the initial concern about cross-reactivity between cephalosporins and penicillin allergies may really not be clinically something that it needs consideration, that it is safe. And so we do use cephalosporins in patients with a history of penicillin allergies. Now, if it's a severe allergy they had, or certainly if they have a cephalosporin allergy, then we'll look at something like clindamycin. So that's our typical approach here.
Great, thanks so much, Matt. Yeah, we're our department, we is ANSEF for most patients. Again, according to our local guidelines, even if patients have hives to say most penicillins, we still offer it. Patients that have severe allergies, our local guidelines are to clinda-gent, gentamicin. So that's what we prefer. Any other thoughts on antibiotics? And then I'd like to move on to say Dvt prophylaxis, which Stephanie brought up in her presentation. I think it's gonna reveal some interesting stuff. Any other thoughts on antibiotics, group? Okay, so Stephanie brought up in her discussion about Dvt prophylaxis. They do this outpatient interstitial therapy. They encourage patients to move and walk around. Ours are generally on strict bed rest during inpatient admissions because that's how we do it. So Stephanie, what do you think about Dvt prophylaxis? Do you ever give heparin or Lovenox? And let us know your thoughts, and then we'll ask the others what everyone else is using.
Sure, thanks. So, for patients who are on therapeutic anticoagulation for cardiac reasons or something, we actually, as long as it's okay with their cardiologist, will have them hold that for about a week prior to an interstitial implant, which is the most common time we use ISI needles for GYN cancers. And then, once the implant is in place, as I mentioned, we don't use routine anticoagulation. And for the patients who are admitted to the hospital, they're admitted to our GYN service or GYN ONC service. And we actually had to do quite a bit of teaching and discussions with them to not do prophylactic Lovenox, to not keep them on bed rest. So currently, I think what happens with the patients who are admitted is that they are required to wear SCDs while they're in bed. So totally fine with that. But we have our brachytherapy nurses give teaching sessions to the GYN floor nursing staff about mainly how to help the patients get up out of bed and how to help them move with the implant. They don't have to use the restroom for any reason. We do the peri-care, the cleaning of the area every morning when they come down for treatment. So our approach to the inpatients is to sort of just leave them alone as much as possible. And we do as much of that management as we can. And we have not had a patient develop a DVT, but clearly, everybody's sample size is only as big as it is. So there is probably some risk of that.
That's really helpful. I think Stephanie brings up a really important point about educating GYN-ONC. So, and not just GYN-ONC attendings and fellows and the gynecologic residents, but also the floor. Floor nurses take care of your patients, and they need to know exactly what's going on and how you would like them to be optimally managed according to your and the local guidelines. So, any other thoughts regarding Dvt prophylaxis? Anyone use, say, Lovenox routinely during admission, or heparin 5000 Q8 routinely during admissions?
Yeah, we use the heparin sub-Q during admissions, and we just have them hold it about 6 hours before the pull.
Yeah, we do as well, and that's ours. Our Dvt prophylaxis is synced up to like standard hospital regulations for it, so that's what we have them follow. But I just wanted to follow up. I think that's a great point about educating the inpatient team. We actually, in between BID fractions for our GYN interstitial patients, we'll keep them in our department rather than sending them back and forth. And there's two reasons for that. One is that we found the highest risk time for applicator motion is during transfers, specifically going from bed to rigid stretcher, because it's like very different heights and surfaces. And also we want to reduce the chance that someone's going to mess with anything. So we just want to communicate to them that we'll take care of the care and just to sort of like be hands off for the implant. So.
It's a fine line. You don't want to make them feel like they're just hotel staff, you know, but we have had some unwanted interventions from the floor in the past.
Pete, your thoughts on that?
Yeah, well, just a comment. You know, as when you build a program, and these just excellent presentations and very detailed on the patient flow and management, but it's also the team flow and management. And you're a leader of your brachytherapy program, and it takes communication among many departments. And I've had experiences before just with these. When we first were doing HDR brachytherapy, we'd keep people for prostate cancer, we'd keep people multiple nights. And the urology resident would write for narcotics, and their default was always to write for stool softeners as well. And you can imagine how that would happen. And, you know, you'd have a different resident every day, but you had problems with that. And Stephanie pointed out how she keeps her patients on stricomodium for her BID 4-day treatment. And it's that detail and the communication with the team at multiple levels. I do a lot of anesthesia consults prior to going to the operating room, because my anesthesiologist, as I get to know them more and more, they just want it. And it does improve patient care. It does prevent, I think, events, and especially with these people with, you know, 1 or 2 comorbidities. And I've just empowered my nurses to be able to send that on anybody. And with Epic, you know, you have pre-filled out order sheets, and it's very easy to do. So, you know, considering all these events that are all these just, you know, very technical tips that were offered today, it's very important for a successful brachytherapy practice. And the sum of it is a successful practice. We take risks in what we do. It's not chess where there is a formula to win at all aspects. It is more like poker, where you can have a perfect plan and still have a bad or a marginal outcome. And, you know, but if you go to the OR with these preparations and with this in mind, you know the beginning and end of how it should go. And like, I love how Matt said, you have multiple plans for if it goes wrong, several layers, and you've thought it through and you practice with your team, you're going to overall have a very successful program. And I've just loved everything that's been offered today. It's been really educational for me.
Great, thanks so much, Pete. A couple announcements. There are SAMs that are available for this in the chat box. So there's 5 questions, and you can get SAM's credits. And then in addition, all of this discussion will be posted on the ABS YouTube within a couple days. So we've got some time. You know, we're getting some great questions that are coming in. Let's talk about some peri-procedural or potentially some intraoperative things. So let's start with Matt. Matt has really hammered home the idea of prepare, and then prepare some more. And then, so you've done some preparations. Let's talk about some more specific medications that you like to use. Antibiotics we talked about, prophylaxis we've talked about with other panelists. What are your thoughts on, you know, say post-operative nausea, vomiting, and peri-procedural pain, Toradol, opioids? Do you use 5-HT inhibitors? Do you use Decadron? What do you like for these types of things? So Matt, let's see what you got, and then everyone else maybe we'll chime in.
Yeah, so you know, it's I think we have the benefit of the fact that we're doing all our procedures, the vast majority of our procedures, under low-dose spinal anesthesia. You know, bupivacaine blocks, really saddle blocks. You know, we're doing these as outpatient procedures. Even our interstitial gynecologic procedures, we're doing multiple implants on different days, all, you know, getting the patient in, doing it. And so I think one of the things I've observed is the pain control with that approach is excellent. I feel like the residual effect of the spinal anesthesia really carries the patient through that recovery when they'd be having that pelvic pain. So I find myself not having to use so many opiates in the post-operative setting. in a patient with good kidney function with a low bleeding risk, I really feel Toradol for patients that do have pain is tremendously effective. It really does help. It helps without that, CNS suppression of high dose opiate, fentanyl, Dilaudid, those types of medications. So in terms of pain, that's what I look to. We've also been using IV Tylenol, which used in coordination with Toradol is a very effective pain medication as well. So we'll use 1,000 milligrams of IV Tylenol along with the Toradol. In terms of nausea and vomiting management, well, most of our patients do get Decadron right at the beginning of the procedure with the pre-op antibiotics. So we typically give 8 milligrams of IV Decadron. I feel like that, for my prostate patients, we're also doing that for a reduction in prostate swelling, but I think that carries through and also does help with some postoperative nausea and vomiting. And then if they're still having nausea and vomiting, we'll go to medications like Zofran and oral disintegrating tablet. And I found that to be very helpful.
Great. Thanks so much, Matt. So Matt introduces, a lot of thoughts on different medications that could be used in different situations, but also the idea that not every one of these things that have to be done under general anesthesia. Using the most appropriate type of anesthesia for that case might be great. So Martin had also brought up in his presentation about epidurals and PCAs. Martin, how do you arrange these things and what's your experience in terms of pain control? So PCAs come in different flavors. They have basal rates. They have demand rates.
Yeah.
You don't have to necessarily explicitly say your settings unless you know them. But what are your thoughts on that?
So, pretty much we give PCAs for almost any patient that's admitted. We use pretty much dilaudid PCAs, no basal rate, but just no continuous rate. But they can get boluses like 0.2 or some like a small dose for boluses. For large interstitial implants, maybe more than 10 catheters, sometimes we recommend an epidural just to help numb everything. I would say the epidural works about 80–90% of the time. And if a patient needs some catheter manipulations, it's much easier for us to do that. But it does take a little bit of extra time, maybe 30 minutes to an hour beforehand. So usually those are kind of what we do for pain for the admitted patients. Outpatients, they're usually fine when they wake up. It's more of the nausea, vomiting.
Great, that's super helpful. I mean, epidurals do require some care coordination, discussion with the patient. Sometimes patients want to know that an epidural is going to be placed. Some patients have never had one before, so it is important to understand those things. Stephanie, let's also talk about pain control. There's a question that came up earlier about paracervical blocks. How do you guys do them, and how often do you do them, and how much do you like them? And also, who taught you how to do them?
The answer to the last question is Perry Grigsby. So I was really fortunate to train here and benefit from his extensive experience. We don't use them very often, honestly. If there's, many women will do really well with the implant. If we're talking about a tandem and ovoid or a Simon-Hayman capsule. More commonly, if they're having pain, I try to tease out what kind of pain it is. So the more common type of pain, I think, is the from the intercavitary devices causing cramping, uterine cramping. And a cervix block isn't going to do anything for that. So we don't bother with trying it for those patients. But I will put in a second plug for Toradol. I think for those patients who have crampy pain, particularly if it persists after the implant is in place for a few minutes, then we'll give them some Toradol, and that can be very helpful for that crampy pain. If the patient is pretty clearly having a lot of discomfort just with any manipulation of the cervix or oftentimes the tumor, we'll try a paracervical block. And for that, just injecting about 10 to 20 cc's of lidocaine into the 3, 6, and 9 o'clock positions of the cervix. Oftentimes the anatomy is completely disrupted by tumor, And you can feel that when you're doing the block because there's no resistance on the syringe to inject the medicine. And I think that those are the patients who are very unlikely to benefit from it. So you can almost tell while you're doing it whether it's going to help or not. For the patients who, what I'll usually do is if I think it might be helpful, I'll do one and then ask the patient for feedback. Did that seem to help? If so, then we'll do it again the next week. Because just like with any local administration, it hurts to do the injection, and there's often some burning pain with just injections of lidocaine. So sometimes it's a wash whether it's actually helpful or not. But we're really, speaking to the point of the team working together and how important that is, we are super fortunate to have a great team of dedicated brachytherapy nurses and therapists. So every patient during every implant, whether it be just a cylinder implant or a tandem and ovoid or ISI, we have a nurse in the room at all times at the head of the bed, talking with the patient, helping them work through the procedure, whether it be with breathing or relaxation, which can make everything a lot easier for everyone involved. And just monitoring their pain. So if they're still having a significant amount of pain after giving that pre-sedation or the pre-procedural medicines, then we'll give them additional Dilaudid, usually by IV. If it seems to be more of an anxiety thing, then we'll give them more Ativan to help the patients relax. But yeah, and then while they're in the bay for the tandem and ovoids, most patients are fine with what we've given them already. Many patients will nap while their plan is being developed. But for the ISI patients, as I mentioned, I think maybe a testament to our female patients, really just do really, really well with minimal discomfort for the most part.
Great, thanks so much, Stephanie. So let's shift gears a little bit. Let's talk about some care coordination, and then we'll shift on to start rounding it out. The best things that you did in terms of everything but the implant, in terms of preparation or intraprocedural or post. So let's go to Tim. Tim had worked, really, really hard working with GYN and urology to kind of coordinate care and use other clinics to their advantage. And Tim, could you speak a little bit about how you start that conversation and how those providers are involved in your cases, if they are really at all?
Yeah, so I would say what in the genesis of our program, and as we were building and rounding out our different procedures, one of the best investments, or absolutely the best investment, was spending time with our nurse, our brachytherapy nurse, who basically schedules everything, understands, she's the point of contact. So anesthesiologists, urologists, GYN-oncs, and all of their staff will contact her directly. And she also is directly in contact with patients. So when something comes up and we need, to plan for post-operative care, we need to have extra cardiology assessments done, it's always Donna that's taking care of it. And that in order to empower someone to do that requires giving them a pretty strong foundation in the nuances of each procedure and what are the different planned requirements so that they can have an informed conversation with whoever they're talking with on the phone. And that takes a lot of time. As a radiation oncologist, someone's going to have to train that person, and then they're hugely valuable to you. So you have to cherish them all the time. And so I would say that's like really a key part of our overall program, and definitely worth the investment in time.
Great, thanks so much. Tim brings up a good point, is as everyone in the ABS is you may have trained at an amazing place with a lot of resources, but Rome wasn't built in a day, and neither is your world-class brachytherapy program. It takes a lot of time and a lot of coordination, a lot of buy-in from both your team and other teams to make it work. Let's briefly talk about admissions. I know Pete, we talked some time ago about coordinating care and order sets to streamline admissions. How'd you get that conversation going? And I know Martin has done the same, and we did the same.
Yeah, and maybe direct to the point. I in building programs, I try to get all the key players together at the same time. And that includes the OR PACU folks and IT, anesthesia, and the nurses that are involved. And it's really key to explain what you're trying to achieve and where you're going with it. And it generally reduces obstacles. And I continue those conversations with like longitudinally, just so, so you can just ask the question, what are you seeing? What can we do better? And always regrouping to kind of make sure we're doing best practices, we're having efficient care. But one thing in particular is, coming up with order sets and practicing them, and also, practicing patient flow. So I do outpatient procedures for GYN and prostate, most commonly HDR. And, when the patient enters really as it begins a couple of days before entering the ground, and what the patient flow is after the procedure is really important. And I challenge the nurses of the PACU to get together with my nurses, and they'll actually walk around the hospital with dry gurneys on Friday afternoons, just practicing what the patient flow looks like, reviewing the orders for what their expectations are for, say, pain control. And, I think it's just really important to kind of establish that leadership early on, because so nothing is reactive, and that you have a plan for anything that may happen during the day. And I hope that answers your question. It's just a big part of, building a program is creating this communication, like I said, longitudinally.
Great, thanks so much. And Pete's advice about longitudinal is incredible, because once you've built the program, you're iteratively trying to make it better and keep up the safety and keep up the quality, understand what your outcomes are. And it is important to make sure that each key stakeholder in your program remains engaged in your program, and all in the spirit of the best thing for patients. So let's start wrapping up, and let's do, the one best thing in terms of everything but the implant that really helped care in your patients or helped out your life in terms of taking care of your patients. And it may not have to be one thing. So I'll start, and I'm going to do two. So the first best thing was Decadron. Decadron was great for post-operative nausea and vomiting, as well as peri-procedural pain. We follow our local guidelines, and that was really valuable. And the second best thing is really getting our anesthesiologists invested in our cases. So we have an anesthesiology residency training program as well. And anytime we get a new resident, an anesthesia resident, we know who they are, and we know if they're new, and we actually invite them to come to the bottom of the table and just take a look at the procedure, or take a look at the implant when it's done. And it's really helped accelerate some of the investments that anesthesia has made into our program. So those are the two best things that we did in terms of everything but the implant. Matt, how about let's go to you. Well, everything but the implant. What was your best thing?
I think that we're all lifelong learners, but I think the best thing that I've taken away from my practice is teaching. I love teaching. And I don't just mean residents or medical students, although I love that aspect. Our nurses, our techs, residents that come from other services and just want to learn what brachytherapy is. And, I find when you can really distill something down and be able to explain it to someone who, let's face it, our field is kind of a black box, right? Even to other physicians. So when you can really distill something down and teach it to someone, your level of understanding, my own level of understanding, that has really helped me the most. So I think teaching and whatever your setting is, whatever your practice setting is, share knowledge, share techniques, just like we're doing now. I think that's the best thing that's really improved my practice.
Yeah, that's awesome. And we're all constantly learning from each other. And these are always these informal back of the hallway conversations. And, I text a bunch of people on this call, random questions about how you execute X, Y, and Z, and it's just really helpful. Stephanie, what was your one or two best things, everything but the implant?
I struggled with this one because I had almost nothing to do with the setup of our workflow or how things work in our brachytherapy suite. But I think probably I guess I would say two things as well. One of the biggest things that helps the patient experience work so well, particularly because we're doing these all, without general anesthesia, is the nursing. Our staff is just phenomenal, and our therapists who walk the patients through every step of what's going to happen during the day that they're there. We're constantly checking on them and communicating with them about how they're doing, when we're not, the physician isn't in the room, and then helping us address any issues that arise. So I think that's absolutely key to the success of how our program works. And then maybe the second thing, which I think helps kind of tangentially, is the in-department MRI. It really gives us a lot of information to pre-plan the implant. From the week prior image, we know how things have changed. We know what we might need to do differently. We know the trajectory of the uterus, everything that just helps that implant go much smoother once we're sitting at the bottom of the table. So I guess those are the two things I would say.
Yeah, that's awesome. And Stephanie starts to bring up the idea of having really everyone invested in your care, and even there are still opportunities to grow in a still robust and established program. Martin, let's head over to you. What do you think? Everything but the implant, everything but the needle. What do you think?
Yeah. So one thing I think is excellent PAs and fellows who can help kind of manage a lot of the peri-procedural issues, make sure that patients are scheduled appropriately, that resources are allocated well, that all medical issues are ready before the implant. That is so helpful that we have that support to help us do that. And the second thing is, we have every 2 weeks we have meetings with cross-disciplinary meetings for the therapists, the nurses, the physics, and the MDs, where we really just hash out issues and make sure that everyone's concerns are raised and discussed. And I think that that's also been a very good way to make sure that everyone's on the same page and all issues are kind of taken care of. And we go through like safety events or concerns with we have a glitch log where things didn't happen where we wanted to, and we're kind of recording this. And so this has also been really helpful.
Great, thanks so much, Martin. I think Martin highlights, again, communication is key in understanding when these things are scheduled. Tim, everything but the needle. And again, this is all in the spirit of creating not just a great implant, but a great safety culture, great quality culture within your program. Your one or two best things.
So I think my one best thing is that I think that especially if you're at a smaller program like University of Virginia, a important goal is to think about on an annual basis how many more of your colleagues are comfortable covering brachytherapy procedures. And I don't mean that because it's easier to take vacation. What I mean is that if that's true and you're incrementally building steam, then you're building more of a program, and you always learn more, and you have a safer environment. You have better peer review when more people know what's going on. And it does take time. You have to train people up. You have to get them comfortable. You figure out what they're able to fit into their schedule. You have to write up policies and provide coverage guidelines for certain elements of it. But it's a really meaningful goal because, we basically went from just me covering, with no one else to check my cases in peer review conference to having, 3 of us who could all cover a prostate HDR case and can really, take a discerning eye in SIM conference for evaluating plans. And it's really paid dividends. It's definitely worth the investment of time.
That's awesome. Thanks so much, Tim. And again, Tim has built a large program out of a smaller place, and really there's nothing stopping anyone from building a practice that's quite similar and attracting patients to a high quality program. So Pete, Pete's been doing this for a minute, doing brachytherapy. What's your one best thing over the many years you've been doing this? And then let's hear from Pete, and you'll do some closing remarks for us as well.
Yeah, so 2 quick ones. One is nurse empowerment in your procedures, or another way of looking at it is reduce the power differences from the beginning. Our nurses come from an oncology background, not procedural typically, And I send them up to urology and gynecology to see what goes on in those clinics. And then I empower them on every procedure to tweak the orders, make the pain control better, all the instructions, whether it's consent or anesthesia, but really make them a principal part of the program that way. You're not in this alone, and they bring a lot to the table. Second is, just kind of piggybacking on what Tim said, talk to your chairperson, let them know who you are. As brachytherapists, and especially in academic centers, and in big practices, we grow in leadership and other obligations. You're a director of a facility. We have all these AU issues and coverage, but you're in the OR 20 hours a week plus, and you're just out of pocket differently than your colleagues. Your coverage is different. You need to take care of yourself, and it starts with talking to your chairperson about your needs and how you should be viewed with that lens. It's very important to your personal success and your practice's success, but and to your well-being.
Great, thanks so much, Pete.
And Neil, you're going to share your two. Oh, you did. You started off, right?
Yeah, Decadron.
Yes, yeah, that's wonderful. And these
just changed my practice. I'm trying that.
These conversations are all, they, like Matt said, we're lifelong learners, and there's always stuff we can do better. These live conversations with Q&A really, I hope it's been meaningful for the membership and the viewers to bring out their questions. I've gotten a couple emails that have been fantastic, and keep it coming to the ABS, keep it coming to the panelists here. We want to learn from you as well, and we want to, create the safest environment for our patients. I want to thank everybody for joining today. Remember, the virtual meeting registration is open. There's going to be another virtual online event next month on skin, led by Mitch Kamrava, reviewing the new guidelines and also 3D printing applications, which is going to be exciting. We're going to have both GU and GYN workshops in August and going into the fall. There's podcasts that are really fascinating and interesting on the ABS website. And this virtual online event today was recorded, and it's going to be posted on our YouTube channel probably within 48 hours or so, so you can view again and share with your friends, share with your team. So thank you, everyone. We really appreciate everybody's attention today and everybody's participation.
Great, thank you all.
Good night.
Yeah, good night.
Yeah, great job, Neil.
Everyone.
Great job, everyone.
Thanks, everybody.
Thank you.